Okay, so I have 5:30. Many people will peter in uh, while we're doing the introduction here. So happy New Year to everyone, and welcome to the third annual Canadian Ophthalmology Update and Review Lecture Series. My name's Ed Soling, and I work at the University of Alberta and the University of Toronto. My co-host is Dr. Rahul Sharma at the University of Toronto, and he'll be running many of this year's sessions. So the triple aim of this series of 10 90-minute lectures is to 1. Provide residents with an organized review for their OCAP exams and Royal College writtens this March. 2. To offer medical students considering ophthalmology a broader perspective of our specialty. And 3. To give practicing ophthalmologists a free, concise, and practical refresher across the major subspecialties. When I was a solo private practitioner with a young family 25 years ago, carving out a full week to travel and attend a review course was extremely difficult. My hope is that these 20 hours of evening lectures will fill an unmet need in Canadian ophthalmology. For those of you who need CME credits, ensure you register with Yitka Foresta and complete the lecture evaluations each week. Now, condensing the essence of an entire subspecialty in just 90 minutes is a titanic task, and I'm very grateful to the university professors on this poster for their dedication and expertise that they put into their finely crafted talks. Tonight's speaker is Dr. Sama Sabeti, an accomplished cornea, anterior segment, cataract, and refractive surgeon. She completed her ophthalmology residency at the University of Ottawa, an anterior segment fellowship at the University of Montreal, a Master of Public Health at Harvard, plus global health internships and a fellowship with the WHO and the Duke University Global Policy and Governance Program. She's a rising professor at the University of Ottawa with a particular interest in corneal ectasia and quality improvement. Her practice affiliations include Precision Cornea, the Ottawa Hospital, Children's Hospital of Eastern Ontario, and the Herzig Eye Institute of Ottawa. She's also the Director of Research at Precision Cornea and the Herzig Eye, Ottawa. So on top of all this, she's a classically trained pianist and music composer. We are indeed privileged to have this multi-talented titan teach us about cornea and anterior segment diseases this evening. So I'll stop sharing. Take it away, Dr. Sabeti.
Thank you so much for the kind introduction, Dr. Ng, and to Dr. Sharma as well for the invitation to be involved in this course. It's a wonderful opportunity to be here, and I hope that whoever's listening gets at least a few pearls out of tonight's lecture. As Dr. Ng mentioned, it's really hard to condense a subspecialty into 90 minutes, so I'm going to jump right in. I've distilled it down to 10 major disease pathologies that we either see commonly clinically or are pathologies not to miss or that need prompt care, and also just simply pathologies that are very highly examinable, which we might not even see very often in clinic. In the lecture, you're going to see various colors. Blue is meant to just stand out to you as highlighted facts, but focus in on the red text. Those are actually questions that, in my experience in the past, have been on various types of examinations. So without further ado, we're going to jump right in. So I have no financial disclosures that are pertinent to this talk. So we'll start off with the tear film, just basic anatomy physiology. It's important to remember that the tear film is composed of three major components: mucin, which is secreted by goblet cells of the conjunctiva; aqueous, the aqueous layer, which is secreted by the lacrimal gland and the accessory lacrimal glands; and the lipid layer, which comes from the meibomian glands. And all of these are required for a functional tear film. And tear film functions in general include not just lubrication, but also providing a source of oxygen and nutrients for the cornea, as well as regulatory factors for epi-maintenance and repair, as well as defense against microbes. Finally, you'll learn in the optics session of this course, I'm sure, about the importance of the tear film in providing a refractive surface for the eye. So Anatomy, the main aspects of anatomy to be aware of are the 5 layers of the cornea, and I'll mention a 6th that has been recently described. We've got the epithelium, under that, the Bowman layer. Stroma makes up the majority of the cornea, followed by Descemet membrane and endothelium. So the epithelium is typically about 50 microns thick. It contains non-keratinized stratified squamous epithelium and is usually about 5 to 7 cell layers thick. It secretes its own basement membrane deposited by the basal epithelial cells. And remember, whenever we have a true basement membrane in regards to the cornea, we're talking about consistency of type 4 collagen. So if there's a different type of collagen involved, that's a trick to help you remember this for your exam. So type 4 collagen composes the basement membrane of the epithelium. And you will be examined from time to time on the actual names of the components of the epithelial barrier. So the epithelium is the first barrier to exogenous microorganisms and debris. And so it's important that there are the epithelial cells have interdigitations between one another. They've got desmosomes, tight junctions, also called zonula occludens, adherens junctions, hemidesmosomes, and these occur in the various layers of the epithelium. Now, I'm going to intersperse with questions here and there. So is the corneal stroma stronger anteriorly or posteriorly? So the anterior 40% of the stroma has twice the tensile strength of the posterior 60%, and we'll learn why shortly. Below the basement membrane of epithelium, before stroma, is the Bowman layer. And actually, Bowman layer is technically the most anterior part of the stroma. It's not a true membrane. And see how it's made up of type 1 collagen. It helps maintain the shape of the cornea, and it's not restored after injury. So a classic example after having PRK, for example, which goes through the Bowman layer, that's not actually regenerated afterward. It's replaced by fibroconnective tissue. And then the stroma makes up the bulk of the body of the cornea. It's mainly composed of type 1 collagen. The water content is approximately 78%, and this is a specific balance that's maintained by the endothelial cells. Keratocytes make up a small percent of the volume, more numerous in the anterior stroma. And then 70% of the dry weight of the cornea is a collagen fibril lattice and an extracellular matrix. What's interesting is that the mean diameter of and distance between these fibrils are less than half the wavelength of visible light, and the regular arrangement of these fibrils is crucial to contributing to a phenomenon called destructive interference, which reduces light scatter and maintains the transparency of the cornea. So if these become irregular because of infection, trauma, etc., that's how we get scarring and loss of transparency of the cornea. The same goes for edema. The collagen fibrils are more regularly arranged and densely arranged in the anterior stroma, and in the posterior stroma, there's minimal interlamellar connections. And this speaks to what we just spoke about with respect to tensile strength. Proteoglycans, the major ones are lumican and decorin. And so these you can read further in your BCSE AAO manuals for further detail, but I just want to highlight key things to know. One novel layer that's been recently described is the Dua layer, about 15 microns thick, just between stroma and Descemet membrane. And where this comes up as clinically relevant is when we're doing DULC surgery, deep anterior lamellar keratectomy, keratoplasty, excuse me, we inject a big bubble to separate the stroma from the Descemet membrane so that we can remove the bulk of the cornea other than Descemet endothelium and place a new transplant. And it's been found that if the bubble's injected above Dua layer, what remains is actually sturdier than if it were to be injected below Dua, leaving just Descemet. So the risk of perforation and consequent need to convert to a full thickness penetrating keratoplasty would technically be less in cases where you obtain a type 1 bubble above Dua layer. And then Descemet membrane, again, a true membrane deposited by the endothelium made up of type 4 collagen. This is 10 to 12 microns thick. One thing that is testable is that the anterior Banded zone is congenital, it's present at birth, and then throughout life, we deposit gradually a posterior non-banded zone. So the mnemonic ABC can help you remember that. And then Schwalbe line actually defines the end of Decime and the beginning of the trabecular meshwork. And the endothelium. So this layer maintains corneal clarity by two mechanisms. One is that it's a physical barrier to aqueous humor, and two, through its ion transport system, namely the sodium-potassium dependent ATPase pump. The cell shape is mostly hexagonal, and cell density at birth is about 4,000 cells per millimeter squared, and by adulthood, it decreases to about 2,500 cells per millimeter with an average decline of 0.6% per year. And the cell count is typically higher in the periphery. Now, what's important about these cells is that they are not found to, or there's no evidence that they replicate in vivo, but they do replicate in vitro, which is important for other potential therapies that we have coming in the pipeline in terms of cultured endothelial cell therapy for patients needing endothelial cell replacement. In the case of patients who have surgical trauma to their endothelium, for example, if a small area is hit and we lose our cells there, it doesn't necessarily mean our whole cornea is going to decompensate and we're going to need an endothelial transplant. In many cases, depending on the nature of the size of the area that's removed and the capability of the peripheral endothelial cells to come in and heal that area, what we know is that surrounding cells hypertrophy and they attempt to spread over the area rather than replicating to fill the area. This is the principle behind DSO, Decime stripping only, which I'll talk about later as an alternative to endothelial keratoplasty in patients with early Fuchs dystrophy. And finally, morphometric parameters that are important for the endothelium. So the coefficient of variation, this is a term that comes up on specular microscopy, which we see an image of on the left, that helps give us an image and a detailed analysis of what's going on with the cells. The coefficient of variation is equal to the standard deviation of the mean cell area divided by the mean cell area. And a normal value would be less than 0.3. Anything higher than this tells you that that endothelium might be somewhat dysfunctional. The term for increase in that value is polymegathism, increase in variability of cell area. And then the other point to look at on specular microscopy is hexagonality. And the majority of cells, 70 to 100% of the cells should be hexagonal. And if they are not, if there's a lower percentage of hexagonality, that's referred to as pleomorphism. And there's a higher risk of endothelial decompensation post-op if that number is less than 50%, because it indicates that these endothelial cells are not behaving properly. These black spots that you can see on specular here are guttae in a Fuchs patient. This is what a specular would look like in a Fuchs dystrophy patient. And you can see, of course, those excrescences of Decime that show up black on the specular. These are pockets of lost endothelium. So to review, what does a high coefficient of variation indicate? Polymegathism. And what does low percent hexagonality indicate? Pleomorphism. These are key terms that will be examined at some point in your residencies. Where does the cornea get the majority of its oxygen supply from? The tear film. And where does it get the majority of its glucose supply from? The aqueous humor. As we know, the cornea is avascular, so the perilimbal cornea gets some oxygen supply from the perilimbal vessels, but otherwise it's primarily the tear film and the aqueous that nourish the cornea. Now, moving on to examination techniques, I've got the name of a couple of dyes here, and we'll match the name of the dye to the description of the staining. So fluorescein stains precorneal tear film and disruption of intercellular junctions, while rose Bengal stains devitalized epithelial cells. And what is a normal tear breakup time? Speaking of fluorescein now, because that's something that we can use to assess it, greater than 10 seconds. So we instill fluorescein into the inferior fornix, have the patient blink a few times, take a look at them under the slit lamp, have them blink and then open their eyes and hold for as long as they can, but ideally more than 10 seconds, and we can put in a drop of anesthetic before that, um, and help them with holding the upper lid if necessary. And we count seconds. And essentially, if we see evaporation or breakup of the fluorescein before 10 seconds, that may be indicative of evaporative dry eye. So speaking of dry eye, this is a really important topic. This could be a several-hour lecture on its own. Dry eye is multifactorial. There's numerous management strategies, and I'm just going to briefly summarize them. So it's a condition of tear film instability, ocular surface inflammation and damage, and neurosensory abnormalities may play an etiological role. It's increasingly prevalent in older patients and more common in females. And it's really important for all of us to be conscious of the importance of not only how to manage, but really acknowledging the discomfort associated with dry eye. It does take a lot of chair time dealing with dry eye patients, but these are the patients that need some of the patients that need the most TLC, given the level of discomfort and sort of the chronic impact it can have on their life. And there was a study that looked at comparing the quality of life measures between patients with moderate and severe dry eye to those with moderate to severe angina, and found it to be similar impact on quality of life. There are two major categories, as you know, aqueous tear deficiency and evaporative dry eye, with their various causes, as you can see in the chart on the right. And overall, what does dry eye result in? Not just discomfort, but even epithelial breakdown and risk of infections and poor healing and thinning of the stroma, etc. Please note all the images and tables I've taken are from the AO Cornea manual or from Manus and Holland's Cornea 5th edition book, and some from our own clinic. So here I just want to lay out the important points to look at when you're examining dry eye. So the lashes, Schirmer test, fluorescein staining. We can do non-invasive tear breakup time with the keratograph. We can look at tear meniscus height with the same machine. We can do mammography, looking at the gland structure to see how much is atrophied, and assess bulbar redness. So many different tests to look for causes and severity of dry eye. And then, of course, management. I won't go into detail on this, but remember, when you structure your approach to dry eye, there's non-pharmaceutical and pharmaceutical. When I advise lubrication, I personally, as a cornea specialist, I'm always advising preservative-free artificial tears, even if it's less than 4 times a day. I encourage 4 plus. Ointment at night, lid hygiene, warm compresses for 10 minutes a night, not just a face cloth that gets down to room temperature within 3 minutes. I mean an actual microwavable or USB chargeable, consistently warm eye mask for 10 minutes, because the lids need to stay above that threshold temperature and not drop temperature throughout that 10 minutes. Otherwise, the meibomian gland oil that we're trying to sort of liquefy is not going to effectively do so. Conservative measures like a humidifier, moisture chamber goggles are helpful. Punctal plugs, perhaps after a course of topical steroids. Then I may jump over to the right here and consider an immunomodulator like cyclosporin or lifitegrast, or perhaps tacrolimus if they've got significant inflammation of the surface and periocular lid skin. Omega-3s, and for significant cases of MGD, doxycycline and azithromycin could be used. Going back to the left, scleral lenses, I think, are an understated and wonderful treatment for dry eye, especially aqueous tear deficiency. Essentially, it's a lens that sits on the sclera, vaults over the cornea, and provides a water bath that keeps the eye moist throughout the day. Plasma-rich in growth factors, PRP, autologous serum, depending on what you have access to. I prefer PRGF, given it contains more growth factors and less inflammatory mediators. And of course, amniotic membrane, dehydrated amniotic membrane has been described as an in-office therapy, and has been used with good effect for dry eye. IPL, RF, LipiFlow, iLux, these are eyelid treatments that can help with meibomian gland dysfunction, and in-office microblepharoexfoliation exfoliation can help with Demodex or significant staph blepharitis. So as you can see, dry eye is not just, instruction to put in artificial tears and do warm compresses and call it a day. There's a lot that can be done, and a lot of these cases that are severe need escalation of therapy. So jumping into some spot diagnosis questions, what is the below condition called and what is the most likely cause? Sorry, I'm not going to be able to give too much time to think.
Continuous.
Oh, we can have participation too. I'm actually happy with that. I think I heard flictenulosis. This is a flictennial, most commonly caused by Staph aureus, and depending on whether it's an endemic area for TB or if the patient was exposed to someone with TB, this can also cause this. So ask about risk factors on history, and then this.
Question for you, Sam. Sorry to interrupt. We just had a question wondering about the dose of doxycycline in patients with dry eye.
Yeah. So I typically use 100 milligrams a day, and you can use it for, say, 6 weeks, see how the patient responds, and up to several months. Some patients are on it long term, and I might at that point go down to a lower dose, an extended release of 40 milligrams, called Aprelon. I don't feel that more than that is needed in dry eye. In situations where we have a hyperinflammatory state and a corneal melt, I might go higher on the dose. Speaking of doxycycline, really important to warn the patient of UV and GI sensitivity issues afterwards, so risk of skin burn. It's also not to be used in patients who are pregnant or breastfeeding or have liver disease or are on anticoagulation. So we don't just prescribe this willy-nilly, even though you may feel like when you come to our cornea clinics, everybody's on it. You still have to ask all of those questions. So this clinical finding is cylindrical dandruff or lash sleeves, and this is representative of Demodex is the main cause of this. And main treatments for Demodex are tea tree oil lid wipes, so not just any tea tree oil off the counter in the pharmacy, specifically 5% concentration. You can buy actual lid wipes that are infused with the correct concentration from different companies. And there's also in-office microblepher exfoliation that can actually physically remove the mites. It's like a really nice cleaning, followed by the tea tree oil therapy. I typically give that, tell patients to use the wipes every night at bedtime for a couple months, and then I'll reassess them and make sure that I don't see evidence of Demodex. Okay, now moving on to a big topic that we're going to spend a bit of time on because it's highly examinable, and you will see some of these dystrophies in clinic. So we're going to list the key differences between corneal dystrophies and degenerations. So you'll see this is a classic way of comparing the two, and it's helpful for when you're studying. So dystrophies are typically bilateral, while degenerations are usually unilateral. Dystrophies are usually symmetric and central more than peripheral. Dystrophies are avascular typically, while degenerations are often vascularized, and dystrophies for the most part are hereditary, while degenerations are not. Given that dystrophies are hereditary, they have earlier onset rather than late in degenerations. Dystrophies are typically slowly progressive over the course of the lifespan, and there's rarely systemic disease involved. Some of them are associated with systemic diseases, which I'll mention. With degenerations, there may be frequent comorbidity, also given these patients are usually older in age. Corneal dystrophies are classically defined as inherited bilateral, slowly progressive diseases of the cornea without systemic findings. Again, there are some exceptions. Please note that when you're looking at the International Committee for Classification of Corneal Dystrophies IC3D table on dystrophies, there has been an update from 2008 to 2015, where some dystrophies were eliminated, some were grouped a bit differently. So I'll present the new one. They do also give categories to each of the dystrophies. So category 1 means it's a well-defined condition, even the gene is mapped and identified. Category 2 is where the chromosome is identified, but not yet the gene. Category 3, the chromosome is not yet identified. And category 4, it's a suspected dystrophy. We don't have clear evidence for inheritance. And then again, tables in the manuals are key for preparing for your exams and for helping you through memorizing and putting conditions in groups. So there is a table, or if you look up the IC3D's latest paper on the dystrophies, they'll lay out the different genes involved. So we'll start with epithelial and subepithelial dystrophies. The most common is epithelial basement membrane dystrophy. So this is typically actually degenerative or due to trauma, but it was labeled as a dystrophy because it was found to be more common in some families than the general population. So it's thought to have some genetic component in some cases. Essentially, on histology, what we find is that there are abnormal sheets of basement membrane, and these trap the maturing epithelial cells that are trying to grow from the base up. That's the direction of epithelial cell growth, is basal to superficial. As they're maturing, they become trapped beneath these abnormal sheets of basement membrane, and they accumulate within cysts under that membrane. And note that EBMD on exam may mimic trauma. Say if someone comes in with a finger poke to the eye or a recurrent erosion type symptom, do always check the other eye, of course, for EBMD, because that might be putting them at risk for the condition. And if you're seeing these areas of thickened epithelium, you can't forget that you should be suspicious for corneal epithelial neoplasia. If it looks suspicious, and we'll go over the signs of that later, it's best to just remove that material for histopathology. So in general, like I said, this is a pathology of the basement membrane causing abnormal epithelial intraepithelial cysts. On exam, when we look through the biomicroscope, we can see it take on the form of fingerprints, maps, dots, or blebs as they're described in terms of their clinical appearance under the slit lamp. So of these two options, which is the more common cause of recurrent corneal erosion syndrome? It's trauma. So I'm going to take a moment to go over recurrent corneal erosions, because this is a recurring theme in many of the dystrophies we're about to talk about. Anytime someone gets erosions from a dystrophy or from trauma, we go back to these principles of treatment. So how does it present itself? Usually it's sudden pain at night or on awakening, out of proportion to the amount of redness. There's photophobia, tearing. The epithelium may be, you might see an epi defect. You might see epi intact, but looks a little bit irregular or sloughing and with irregular fluorescein staining. You might actually see barely anything, and the patient said, no, I woke up this morning or last night in the middle of the night with pain, or it happened 2 days ago. And you take a look. One key pearl is to look just inferior to the pupil. If you can't see any EBMD signs and you're just looking for signs of evidence of recurrent erosion, just inferior to the pupil in the mid-peripherally, there will usually be at least a few microcysts. And if you see this within the epithelium, you're likely catching the remnant of these micro recurrent corneal erosions. So my first step is always lubrication. If the patient's not using any lubrication, that's what I start and I send them home. I don't jump to a procedure right away, because if lubrication fixes the issue, that's where we leave it off. So artificial tears throughout the day, 4 times a day or more, depending on how dry I feel they are, and then ointment at night. And if they also have significant dry eye, that has to be managed as well with the usual treatment strategy I explained before. Hyperosmotic drops, such as Miro, for example, and the ointment at night, have been described to help with adhesion of the epithelium to the basement membrane. Bandage contact lens if the patient's having significant pain with a large epidefect. In terms of cases that don't respond well to lubrication, I move on to superficial keratectomy with a diamond burr polish. And this has been shown to be effective in over 89% of cases. PTK is also a treatment option, although some in the literature it's described, both are very valid options. Some may consider doing the diamond burr polish first, and if that fails, move on to PTK, or if that fails twice, move on to PTK. That's my general approach, because I've rarely had someone come back after the diamond burr polish, and it's nice to be able to avoid potential issues or healing issues after PTK. And then finally, anterior stromal micropuncture. This has been described previously. I think it's less and less in use. I don't typically use this in my practice, but as long as the recurrent corneal erosion site is occurring outside of the visual axis, one treatment option is using a 25 gauge needle and gently poking into the anterior stroma through the epithelium, and that basically forces the epithelium into these tiny microchannels in the stroma and sort of pins it down to try to help reduce the risk of further erosions. So now, which dystrophy is caused by mutations in the keratin gene? So this is Meesmann epithelial corneal dystrophy. And what intracytoplasmic substance is found in epithelial cells in Meesmann dystrophy? Believe it or not, this is something that comes up on exams, peculiar substance. So we'll talk about Meesmann. So this is an autosomal dominant dystrophy involving KRT3 or a more severe variant, KRT12. Essentially, what happens is we see diffuse, tiny, tiny, tiny epithelial vesicles that look like microcysts across the entire cornea. And on transmission electron microscopy, one would see peculiar substance, which is a term for fibrogranular material within the cytoplasm of epithelial cells. If the patient has painful recurrent erosions, we go down that treatment pathway. Otherwise, there's very little in terms of visual acuity issues in these cases. Leash epithelial corneal dystrophy is X dominant. The gene's not yet known. It is similar to Meesmann in the way of having numerous cysts, but instead of being spread diffusely over the cornea, it's clumped into a sort of a feathery amalgamation. Same scenario for treatment. Usually there's none needed. It's typically not even associated with recurrent erosions, whereas Meesmann may be. So we'll list some differences that we just learned between Meesmann and Leash. Meesmann does not have band-shaped feathery lesions. The Meesmann cysts are not as densely crowded. There are actually clear spaces between cysts, whereas there aren't so much in Leash. Meesmann has more diffuse corneal involvement, and Leash is not associated with recurrent corneal erosions. Moving on to gelatinous drop-like corneal dystrophy. So this is autosomal recessive, and it entails subepithelial and stromal amyloid deposits. Going from early disease to late, we see this mulberry-type configuration progressing to band keratopathy and then kumquat-like type, which obviously is obscuring the visual axis and needs treatment with a transplant. It unfortunately does recur, 100% recurrence within a few years after transplant. So patients have to be counseled on the fact that this happens, but you can, of course, improve quality of life by assisting them with their vision, even if for several years at a time. And of course, the risk of transplant and risks to the intraocular tissue goes up with every surgery, which is unfortunate. The key deposit in this condition is amyloid, which stains with Congo red and shows characteristic birefringence with polarized light, which I'll go over. A little mnemonic to help those studying for their exams. So it's autosomal recessive. Don't argue. You need TAC to gel with Amy. So this was the only way I remembered that gene for gelatinous. All right, so epithelial stromal TGFB1 dystrophies, previously referred to as the big H3 gene, on chromosome 5q31. So Reese bucklers and Thiel-Behnke are dystrophies of Bowman layer, and lattice and granular are dystrophies of the stroma that can also impact the epithelium. So inheritance of Reese bucklers, autosomal dominant. So all of these that we're talking about are TGFB1 autosomal dominant for the next few. Onset is early, within the first few years of life. Patients do have painful recurrent corneal erosions that are more frequent and severe than Thiel-Behnke. Visual acuity can be reduced from anterior scarring. It typically occurs central initially and then over time can extend to the limbus. You essentially see this sort of reticular haze is what it tends to look like, or honeycomb-like. Treatment, you can treat the recurrent corneal erosions per our treatment pathway discussed before, and if a transplant is done, recurrence is common. And if we look at Thiel-Behnke, it also has this reticular diffuse opacities in the cornea, but it typically is more central than peripheral. Recurrent erosions are less frequent and severe, and the presentation is typically a little bit later. So there are ways to differentiate these two, but essentially at the end of the day, when we're planning management, it's a similar approach. So testable items here. So differentiating between Reese bucklers and Thiel-Behnke. Again, not really as clinically relevant to us, but in terms of histopathology, there are nice differences to point out. So histopathology, in both of these conditions, Bowman is disrupted. In Reese bucklers, it's replaced by sheet-like bands of connective tissue. In Thiel-Behnke, it's replaced by a wavy, sawtooth pattern of fibrocellular material. On electron microscopy, which is actually what is needed for definitive histopathological diagnosis to differentiate these two. With Reese bucklers, we see rod-shaped bodies, and with Thiel-Behnke, it's curly fibers. On confocal microscopy, both of these conditions demonstrate highly reflective deposits in the epithelium and Bowman. In Reese bucklers, there are no shadows, though, and in Thiel-Behnke, there are dark shadows. ASOCT is helpful. This is more clinically applicable. I mean, most of us cornea specialists will have an ASOCT in our office. Often you can catch a bit of that sawtoothed appearance of the Bowman layer in Thiel-Behnke. So which stains are used for amyloid? Before we move on to our next condition. So Congo red, crystal violet, and thioflavin T. What is commonly tested is that with Congo red, amyloid exhibits red-green dichroism and green birefringence. Red-green dichroism pertains to when we look under the microscope with a rotating polarizing filter with certain rotation. The amyloid will appear red versus green. And then with respect to birefringence, this refers to a phase shift of light, essentially, that substance, amyloid, can actually change the wavelength of some of the light that comes through. So we can see green birefringence due to that phase shift or retardation of a change in wavelength of light. Crystal violet, amyloid exhibits metachromasia when stained with crystal violet, meaning you see deep purple red amyloid on a blue background. Those are the key ones, I'd say. So we're speaking about amyloid. We talked about gelatinous drop-like, and now we'll talk about lattice. So amyloid deposition in these ropey linear patterns in the anterior stroma. We get this glass-like branching. It starts centrally and superficially and spreads outward to the periphery and into the deeper stroma. There's typically no limbal involvement, though. Recurrent erosions are common and need to be treated, and recurrence is common after transplant, more common in granular than in granular or macular, which we'll go over in a minute. Lattice type 2 was previously something that was described in the manuals as a dystrophy. It is no longer classified as such by the IC3D, and the reason is because lattice type 2, you may recall the term Meratoya syndrome with masked facies. This is a systemic amyloidosis with secondary ocular deposition of amyloid. It's not a primary corneal dystrophy, so it's been removed from our list. Moving on to granular. So the deposited material here is hyaline, and it stains with Masson trichrome. We see clinically these central crumb-like opacities in the superficial cornea with clear intervening stroma. They look like little breadcrumbs. They can get recurrent erosions that need to be treated. If their vision's decreased, you can consider DULC or PKP, but there is risk of recurrence. And of course, in these stromal epithelial dystrophies, we avoid laser refractive surgery given the risk of haze. And then granular type 2, otherwise known as granular lattice or Avellino. This has a combination of what I just described in lattice and granular. So it has the breadcrumb appearance plus some lines radiating out. So it almost looks like a crack in the windshield, or star-shaped or snowflake-shaped. So that means you've also got hyaline and amyloid deposits that we see in granular and lattice. And again, similar treatment strategy. Moving on to purely the stromal corneal dystrophies. So macular corneal dystrophy is autosomal recessive. It's due to an error in synthesizing keratin sulfate and results in accumulation of unsulfated keratin sulfate in the cornea. Mucopolysaccharides are what are significant and stained with Alshin blue. It can involve the entire cornea, all the way to the limbus, all the way to the endothelium. So one way to remember this was just MAC attack. It's diffuse. It affects everything. We can use ELISA to measure sulfated keratin sulfate levels, which we expect to be low in this case. And again, similar treatment strategy as previously mentioned. So bright yellow here for these mnemonics. So you may come up with different things yourselves, but one that I found helpful during my residency was Marilyn Monroe always gets her man in LA County. So this just stands for the disease deposit and the stain. So macular deposits are mucopolysaccharides, which stain with Alshan blue. Granular, the deposit is hyaline, stains with mason trichrome, and lattice, the deposit is amyloid, stains with Congo red. And then I've listed here a few other mnemonics that you can keep in mind for recurrence, age of presentation, and prevalence of disease. So important for you to know the different deposits and the stains and the genes. So TGFB1 gene, like I said previously, it used to be referred to as a big H3. When you think big, you can think of the word large. And if we write out the word large, it creates our little mnemonic here for the TGFB1 dystrophy. So lattice type 1, Avellino, Reese-Bucklers and Thiel-Behnke, granular type 1, and EBMD, which is genetic in just a minority of cases. Moving on to Schneider corneal dystrophy. This is a local disorder of corneal lipid metabolism, but it can be associated with abnormal serum levels, lipid levels in 2/3 of cases. So patients should be checked for elevated serum lipid levels. Lipid stain with oil red O and Sudan black B. In terms of stages of progression, this typically starts centrally as a ring of central corneal opacification. May or may not have subepithelial crystals involved. That's only in 50%, which is why the name crystalline was removed from Schneider crystalline corneal dystrophy. It's not always present. You start with essential opacification, and then after that, we get the peripheral corneal arcus with this intervening clear zone in the mid-periphery, and then that starts to get opacified by the 4th decade, and corneal sensation decreases with age. So again, important to check lipid levels, and if the systemic lipid levels are addressed, that doesn't necessarily help the cornea, and family members should be checked as well for their serum lipid levels. Moving on to Fleck corneal dystrophy, autosomal dominant, a new gene listed here. Essentially what this looks like is dandruff-like opacities distributed throughout the stroma. It involves stroma only, vision is usually normal. Congenital stromal corneal dystrophy, autosomal dominant, involves a decorin gene. Essentially what happens here is the collagen fiber diameter that I told you is important for maintaining transparency of the cornea. It's half the normal size. And so we get this haze that we shouldn't have there. The epithelium and endothelium are untouched, however, unlike in CHED. So there's no edema because endothelium is fine. The central corneal thickness is fine. No photophobia or tearing. PKP might be needed for advanced cases and especially with the desire to prevent amblyopia if severe. And then finally, endothelial dystrophies. So posterior polymorphous corneal dystrophy. You may remember previously we had CHED1 and CHED2, congenital hereditary endothelial dystrophy. CHED1 has been eliminated and has been brought under the umbrella of posterior polymorphous corneal dystrophy. It's one and the same. What we see here is abnormal multi-layered endothelial cells. They look and behave like epithelial cells or fibroblasts. So they can be multi-layered. They have proliferative tendencies. It looks similar to ICE, but ICE is sporadic and unilateral. And then the hallmark of disease is actually these vesicles and railroad tracks and bands on the endothelium. If there's no edema, there's no treatment really needed, but if the patient has corneal edema, they may need an endothelial keratoplasty. And finally, my favorite, Fuchs dystrophy. So it's most commonly without a known inheritance, but some are reported as autosomal dominant. And as time goes, actually, there are more gene mutations being reported as related to Fuchs dystrophy. So endothelial cells are decreased in number and decreased in function. As a result, there's endothelial dysfunction. So what are signs of that we learned before? Polymegathism and pleomorphism. There's different stages of Fuchs. So stage 1 is just corneal guttae, first in the center, and then it spreads to the periphery. Stage 2 is where you actually have endothelial decompensation and your stroma gets swollen. Stage 3 is when that edema has come up to the epithelium now, and the epithelium is involved and swollen. And stage 4 is where, due to chronic swelling, we get subepithelial fibrosis. So obviously, we want to catch this way before stage 4. We want to be able to treat these patients at this point, stage 1 or 2, if the patient is sent to us early enough. Symptoms of edema are usually, my vision's worse when I first wake up. It takes several hours for it to clear up, versus if they had, say they have fuchs and dry eye and it's early fuchs and you're trying to figure out what is the main cause of their visual symptoms. Well, dry eye is intermittent, improves with blinks and humidity, worse than when we go outside in the wind, worse at the end of the day or while watching TV or reading a book. So history matters in terms of determining symptoms, because we don't just do a transplant on a asymptomatic non-swollen fuchs cornea. But if they have guttae that are causing them symptoms, we might even intervene there before they have edema. Specular microscopy is helpful in determining the decrease in endothelial density and changes in those characteristics we discussed before. Clinically, I don't necessarily use this as much in my determination of whether someone needs a transplant. However, I do warn the patient who has fuchs before they have cataract surgery that having fuchs, period, puts you at a higher risk of having endothelial decompensation after cataract surgery. And management, I'll talk about transplants later. And finally, CHED. So there's no CHED 1 or 2 anymore. CHED 2 has now become CHED. Congenital hereditary endothelial dystrophy. This is autosomal recessive. It starts at birth. It's stationary. It causes significant decrease in vision due to corneal stromal edema, stromal thickening. And as a result, nystagmus. And their endothelium is almost is not functioning. There's sparse atrophic endothelial cells and significant degeneration. So these cases that are severe may need corneal transplantation. Okay, so spot diagnosis of everything we just did, and we'll leave the dystrophies behind. So we've got here this map-like pattern, that's EBMD. We've got these diffuse vesicles. We talked about Meesmann. These vesicles that are conglomerated into a feathery shape, that's leash. This gelatinous mulberry-like appearance on the cornea, that's gelatinous drop-like. This honeycomb reticular pattern in the stroma, that's Rees-Buckler's Thiel-Behnke. You'd have to discern that clinically and on further testing. These lesions that don't have intervening clear stroma, it's diffusely hazy, that's macular. These breadcrumb lesions with clear stroma between, we've got granular type 1. We've got lattice, the ropey amyloid-like lesion, amyloid deposition. Granular 2 is has the lattice component, and then fleck, the dandruff-looking speckles. So I hope that was a helpful review. Last bit, the genes involved. So keratin associated with Meesmann, X-linked is leash. You need gel, you need tack to gel with Amy, was this one, gelatinous drop-like. Decarin is associated with congenital stromal. Fleck and Schneider. So important to know your genes for your exams. Autosomal recessive and X-linked are listed here. All right, spot diagnosis. What is the most likely diagnosis here? We see some choractopia, the pupil looks abnormal. There's iris color changes. You can see loss of the anterior stroma. There's iris defect. So iridocorneal endothelial syndrome, ICE. What are the 3 variants? I won't go into detail on what the characteristics are of each, but it's important to know how they differ clinically. And remember, Chandler syndrome is primarily mostly corneal edema, but it can still have iris abnormalities. The demographic, females, more than male, middle-aged, unilateral, and 2 major complications, glaucoma and corneal decompensation. And what's the key factor here is an abnormal endothelium that acts like epithelium and proliferates and moves past where it should and moves into essentially into the angle onto the iris. It contracts, it starts essentially tearing that iris apart or causing iris mammillations, as in iris nevus syndrome. So the key cause is a defective endothelium. What is our diagnosis here? So we see this haziness to the cornea. We see these little, what look like little vacuoles, little holes in that area of opacity. It's almost like a Swiss cheese appearance. So that gives us a clue that it's band keratopathy. typically starts at 3 and 9 o'clock before extending limbus to limbus. That Swiss cheese look is due to corneal nerves penetrating Bowman. So you have an absence of the calcium deposits there. In which layer are the deposits? That's there in the Bowman membrane, calcific hydroxyapatite deposits. And how is this condition typically treated? We work the patient up for systemic causes if we can't identify a primary ocular cause, and then we treat with superficial keratectomy and EDTA chelation to chelate the calcium and get it off of the cornea. And we've got a differential for band keratopathy in our BCSC manual for systemic and ocular conditions. Pingueculum and pterygium. So pterygium is almost always preceded by pingueculum, similar pathophysiology and histology. Main risk factor UV. Other risk factors are dust, wind, inflammation, dry eyes, trauma, welding, so environmental exposures. On histology, key exam question. We see elastotic degeneration of subepithelial collagen with hyalinized connective tissue. With pterygium, because it comes onto the cornea, we also see destruction of Bowman. These lesions might sometimes exhibit squamous metaplasia. There's a rare risk of malignancy. So if there's any questionable features, which I'll go over, they have to be, an excisional biopsy would be indicated. Or if we're suspecting actual OSSN, then one could start with topical chemo. I'll go over that. Indications for pterygium excision, which we nowadays do most commonly with conj autograft to help with wound closure and reduce risk of recurrence. The indications are chronic irritation or inflammation, progressive growth toward the central cornea or visual axis, causing irregular astigmatism or blurred vision, restriction of ocular motility, or in a case where a patient's totally asymptomatic, but they've come into your office for cataract surgery or refractive lens exchange, for example, when you need to take corneal measurements to calculate the power of the lens you're going to implant in the eye, you need to get any barriers out of the way, and also mainly because pterygium actually alters the astigmatism of the cornea in an irregular fashion, so you want to regularize that surface for good quality measurements. Lastly, listed in the manual, technically cosmesis. I have a high threshold for doing this solely for cosmesis. Usually patients will satisfy one of the other criteria. But if it's a tiny lesion and it's not irritating, not causing inflammation, not growing, not causing a disruption of the corneal topography, for example, a pingueculum, I do counsel the patient quite extensively on the fact that we can't predict how that conjunctiva is going to heal after. You may not necessarily have a much more wonderful cosmesis after. Usually they do. Usually it's a nice flat layer of conj that heals, but I wanted to make a note of that. It's not typically my go-to reason. May see a stalker line, pigmented iron line in the epithelium at the leading edge of the pterygium. And then characteristics concerning for malignancy include calcifications, leukoplakia, atypical elevation, irregular feeder vessels, rapid growth, or pigmentation. So for this reason, I send all of my conj specimens for pathology. Even if I feel this is a slam dunk pterygium, just send it. You never know what might come up. So what not to mistake a pterygium for? So this is actually a case of OSSN that may have looked like a pterygium at a first glance. Not all cases of OSSN are this obvious. This is one from my fellowship, massive, massive lesion. And don't forget to evert the eyelids on exam. So first visit, follow-up visits, even after the lesion looks like it's resolved, flip the lids when you're looking, following up patients with conj lesions, always. What are the risk factors for OSSN? So UV light, prior skin cancer, older age, male smoker, HPV, HIV should be tested if a patient presents under age 40, may be potentiated by systemic immunosuppression. When it's non-invasive, we call it CIN, corneal or conjunctival intraepithelial neoplasia. When it's invasive, this is actually a squamous cell carcinoma. So when it's broken beneath the basement membrane. The three subtypes of OSSN, papilliform, which I showed you that previous large lesion, gelatinous, you saw this one as well, and leukoplakic. So it shows up in different forms. These are all OSSN. What are the characteristics of corneal intraepithelial neoplasia? So this is typically a translucent, granular looking lesion on the cornea. It typically has these fimbriated pseudopod-like margins. It's not as evident in this, but clinically, when I've seen it, they almost look like what microvilli would look like if in your imagination when you zoom in. So these pseudopod-like extensions. And they may have free little islands on the cornea. So if you're suspicious, you with any lesion, we treat with topical chemo, and there's surgical option as well. So I'll go over that briefly as well. So if we were to have a small flat OSSN lesion on the conj and we want to try topical chemo first, that's my go-to. Initially, interferon worked beautifully well, but unfortunately it's been discontinued by the manufacturer, so now our options are 5-FU and MMC. MMC is very aggravating to the ocular surface, so I try to avoid it if I can. My option right now is 5-FU. I use it 1% 4 times a day, 1 week on, 3 weeks off, as is seen here in this option. I usually 4 cycles, or I keep going until clinical resolution, and then I do an extra 2 cycles just to be sure that there weren't any dysplastic cells remaining. And for surgical excision, say that massive lesion I showed a bit earlier, for some larger lesions, you could start chemo and try to debulk it before surgery, but with some of these big ones that are growing rapidly and large, we may need to just expedite surgery and go straight to it. And for that, what's important is no touch technique, which I'll go over, 2 to 4 millimeter margins on the cornea and conj, alcohol 100% epitheliectomy on the cornea, and cryotherapy double freeze thaw technique to the edges. So here's one case that I treated with topical chemo. Okay, so we can see this growth onto the cornea, and we can see this abrupt change from normal to abnormal hyperreflective thickened epithelium on ASOCT. After one cycle of 5-FU, I was not expecting this dramatic change. This is what this gentleman looked like. And I continued afterwards for several cycles to make sure that the lesion did not recur. So that's just with topical chemo. This is a case that I treated surgically. Large, thick, elevated lesion. Again, you see this abrupt transition from normal epi to thick and hypertrophied and irregular. And a UBM also can help just assess for invasion to ensure that's not occurring. And so for this patient, we did no touch technique, which means you're never touching the cancerous lesion. You're always working in the margins around, and then hand that off to pathology. And then we switch our gloves, switch our instruments, and that's when we're working on closing the defect. And I typically use amniotic membrane after doing cryotherapy using a double freeze thaw technique. So it literally means you go around the margins and the limbus twice with cryotherapy. And the cells, classic exam question, when are the cells actually dying? That's for us to kill off any potential residual cells at the margin. They die during the thawing phase, not the freezing phase. All right, another spot diagnosis. So this is corneal arcus. If the patient was under 40 years old, what would you need to rule out? Unusual to see in someone that young, so perhaps they have elevated serum lipids and cholesterol. That should be checked. If corneal arcus is seen unilaterally, think of the carotid arteries. Maybe one side is occluded and is not allowing that lipid-rich blood to reach the eye and deposit that cholesterol. So they need a workup with a Doppler ultrasound. And iron lines as they pertain to the corneal epithelium. This is in the manual. You can take a look at that. Keratoconus, I'm mindful of the time, we're going to keep going. So this is the most common of all ectatic diseases of the cornea. There are others, pellucid marginal degeneration, keratoglobus, which is more diffuse thinning. It's non-inflammatory, bilateral, progressive. It involves central or paracentral stromal thinning and corneal steepening. And most commonly patients come in early on. My glasses are just not right. I keep needing to get new glasses. I have ghosting. They may complain of a comet tail to light and letters, coma, due to the irregular sill. Risk factors involve family history, and eye rubbing and atopy are the most important to ask about. And I always ask how they sleep, especially if it's very asymmetric. I can pretty much predict if they're sleeping on their wrist or sleeping with their face in the pillow on one side, and they have to be counseled to change that habit. No pressure on the eyes at any point. Histopathology is laid out in the manual. I won't run through it right now. There are different signs to look for. So now that we have, we have tomography, in cornea clinics, we use this every day on pretty much every patient. But if, say, an optometrist or a general ophthalmologist was to see a patient in their clinic and not necessarily even have the history of changing glasses, or I can't get a manifest refraction to 20/20, these are some clinical signs. So the oil droplet sign, that already demonstrates apical irregularities. Rizzuti sign is when you shine a pen light from the temporal aspect and you get this conical nasal reflection. Munson sign is a late sign, V-shaped indentation of the lower lid on down gaze. And then slit lamp findings, again, unless advanced, you may not see thinning at the slit lamp. Vogt striae, these striations in decima posterior stroma that go away with gentle pressure from above the lid, just gentle pressure on the sclera, and you'll see those go away, and you let go and they come back. That's due to compression on the tissue. Flesher ring, which is iron deposition at the base of the epithelium. Scarring due to breaks in Bowman. And hydrops, which is due to decimate breaks from the strain on the cornea, which allows for an influx of fluid and sudden corneal edema. Remember that ultrasound pachymetry, keratometry, and corneal topography do not rule out keratoconus. They may give you suspicion to rule it in, but they cannot rule it out. Just having a normal measurement on pachymetry doesn't tell you anything about the shape and distribution of the anatomy of that cornea. Having a normal, say, a K value of 44, that doesn't tell me that patient doesn't have keratoconus. And topography is not always going to be as obvious as these egg-shaped Myers. You need to see the whole corneal thickness, and that's with tomography. So we get posterior elevation in addition to anterior curvature and the thickness profile distribution as well. We take all of it all together. This is an obvious advanced case with inferior steepening and corneal thinning with posterior elevation, but sometimes they're not so obvious. When they're not so obvious and we're suspecting there might be something going on, there are some signs that we can look at that these are not diagnostic, nor is there there previously were classification or definitions of keratoconus stage 1, 2, 3, 4. That doesn't exist right now because you may have different features from different stages. And there's no defined pachymetry or corneal curvature that defines keratoconus. It's overall a combination of factors that fit the bill for the disease. So you should be suspicious if K mean is over 47, but it doesn't mean it has to be keratoconic. Decreased thickness at the apex, and the thinnest point is typically deviated inferior. Abnormal corneal thickness distribution, so that the normal change from center to periphery is distorted somehow. I'll show you on the next slide what the bad D value is. Typically, you have increased posterior elevation in that area of thinning, but this is no longer a requirement for diagnosis of keratoconus. Asymmetric bow tie, so when you have inferior more than superior steepening of more than 1.2 diopters, you should be suspicious. Or when you have skewed radial axes, so your superior and inferior wings of your astigmatism bow tie per se, one of them is, you'll see that they're deviated from one another. They're not in one axis. And based on the most recent global consensus on ectasia that's still pending, is to be published, but it was reported at AAO, Kmax has low reproducibility and reliability and should not be used as your determination of whether that patient has progressed or not. This is the bad D, Bell and Ambrosio D value. So this takes into account this corneal thickness spatial profile. What is going on with the absolute value of the corneal thickness at every point in the cornea? What is going on with the relative change of the thickness to the periphery? And saying what's going on with the curvature. And it gives you this number, which if it's above 1.2, 1.4, you should be concerned. This is clearly a thin cornea and is likely ectatic. So keratoconus diagnostics, one other thing to mention, for progression analyses, we're using the Bellin ABCD grading system. So this helps us look at staging and progression from exam to exam. There's actually in the Pentacam software, look at the progression display and it'll show you this. It's based on the anterior curvature, A, B, back posterior curvature, C, CCT, thinnest pachymetry value, and D for distance vision, best corrected distance visual acuity. And these are all tracked from visit to visit and help us understand how the patient is progressing or how they stand compared to normals versus keratoconic progression. Finally, if we have suspicious findings on tomography, but it's not slam dunk keratoconus, and say this person's young and we're a bit worried about waiting 6 months till we see them again to reassess, if we have epithelial mapping available to us on ASOCT, this can supplement our tomography. So what happens when the cornea changes shape? The tomography anteriorly will not catch it necessarily because the epithelium tries to mask that change in shape. So when the cornea starts bulging, the epithelium wants to maintain the original curve or curvature, so it's going to start thinning over the apex and thickening above it to still make it seem as though that cornea is still of the same shape. So actually, by the time it shows up on your pentacam, you've definitely already got your epithelial map changes. This shows up earlier than even posterior elevation shows up on pentacam. So you get thinning over the cone and thickening above the cone. That's classic for ectasia. Two main goals of keratoconus treatment: vision rehabilitation and preventing progression. So for vision, glasses in early cases, but usually with irregular astigmatism and coma, they need something more. So contact lenses, particularly sclerals, can help. These vault over the cornea and bypass the irregular optics of the window. So these help very nicely with not just a high prescription, but irregular, canceling out irregular astigmatism, and can even be designed to cancel out certain higher order aberrations. Surgical management, there's corneal reshaping surgery, which involves either putting a ring segment in to adjust the shape of the cornea, which flattens the center. This has historically been done through PMMA rings, intracorneal ring segments. You may have heard of Intacs. Nowadays, there's a shift towards CARES, corneal allogenic intrastromal ring segments. So instead of a PMMA segment, we're putting in a piece of corneal tissue. This is more biocompatible. There's no risk of extrusion, perforation by the segment. That wouldn't happen. Things like haze, melt surrounding the Intacs ring. These are things that we don't have to worry about with CARES, unless you put in too thick of a segment and you're causing compression of the anterior stroma, then melt has been described. But otherwise, we're putting in a piece of biologic material, which is much more preferable. Another alternative is PRK with cross-linking. So PRK, keratoconus patients, remember, are absolutely not to undergo elective laser vision correction. That is a contraindication. This is not elective. This is medically necessary or therapeutic reshaping of the cornea so that this patient can see better in glasses. So we're trying to reduce, by doing both of these types of surgeries, we're trying to reduce the irregular sill so that glasses work better for the patient. Otherwise, scleral lenses, if they work well for them, they might just stop right there and not proceed to any surgery. And then finally, corneal transplant is a last resort. If the patient doesn't do well with the corneal reshaping surgery, it's a suboptimal result because they're too advanced, poor vision not good enough with their contacts, or their contact lens intolerant, or their thinning approaches a limbus, or they have a high drop scar, then we're talking DALK or BKP. And then prevention of progression, no eye rubbing, absolutely important that they get counseled on that, because even if you cross-link them, if they continue to rub their eyes or put pressure on their eyes and put their face in the pillow when they sleep, they're going to progress. So it's really crucial that you remind these patients absolutely no more as of this moment, no more eye rubbing, no pressure on the eyes. We need to help patients who, why do they have a tendency to rub? Sometimes it's a habit, but sometimes it's truly due to itching, atopy, dry eye. So treating the source of inflammation. And even inflammation itself, even if the patient stops rubbing, if the eye still has inflammatory molecules on it, studies have shown that keratoconus can still progress. So it's part of the pathophysiology. And then cross-linking is what we do to help freeze the cornea in position. Actually, it tends to flatten the cornea with time, but the goal is not, we don't promise a patient they're going to have improved vision or anything, and there are risks to cross-linking, including haze and melt. But the goal of it is to try to halt progression. It uses UV light, a photosensitizer, riboflavin, and oxygen to react with one another and essentially strengthen the collagen bonds in the cornea. Now, shifting over to a whole different topic. So, cicatrizing conjunctivitis, important topic for you to know and to identify, especially because some patients who may have advanced or severe dry eye, if you look in their inferior conjunctival fornix, they might actually have symblepharon or fornix shortening that was missed. So never forget about the possibility of cicatricial conjunctivitis. And I'm going to talk about mucous membrane pemphigoid for a moment, previously known as ocular cicatricial pemphigoid. When we biopsy these cases, we take I'll tell you where we take the piece from. First, I'll tell you about the biopsy. We send one sample in formalin and one sample in Michel media, the latter being for direct immunofluorescence. And what it does is we see linear staining of complement 3, IgG, IgM, or IgA in the basement membrane zone. If those immune deposits are present, they will stain and fluoresce and give us evidence of mucous membrane pemphigoid. And then the sample in formalin essentially goes for the usual histology that we need. So we see epithelial bullae, subepithelial bands of chronic inflammatory cells. So here's a picture of that direct immunofluorescence. And then where is the best area to obtain a sample and what's the sensitivity? I typically sample just adjacent to just an area that involves active and inactive zones. So if you can find a symblepharon, go just adjacent to that. And I go into the fornix, essentially, is where I'm sampling, and enough tissue so I can split it to send one to each media type. And sensitivity is as low as 50%. So if you have a negative, it could be a false negative. And if you have a strong clinical suspicion that this is indeed MMP, you may consider just proceeding with treatment if you're convinced. So that's something that that one would need to liaise with rheumatology for. And then with respect to the 4 stages of MMP, don't forget to review your Foster staging. I'll just say, don't forget this subepithelial lacy fibrosis and fornix shortening. Those are the first signs before you get the obvious symblepharon. So don't forget to avert the lids to look for that. Limbal stem cells, where are they located? In the palisades of Vogt. Typical turnover time, 7 to 14 days, from the limbus to the basal epithelium and up. 2 main functions: repopulation of the epithelium, and they serve as a barrier to conj growth and vascularization over the corneal surface. And how much of the limbus should be intact to maintain epithelialization? About a third. In terms of findings, classic findings that are examinable, you put in fluorescein, give it a few minutes, talk to the patient, leave the room, come back. You may see this late whorl-like or vortex staining from the limbus central to the center or towards the center, indicative of abnormal limbal stem cells. Columnar keratopathy, so this alternating columns of normal and abnormal fluorescein uptake. Corneal neovascularization, pannus, and even conjunctivalization of the cornea with presence of goblet cells in the cornea, which shouldn't be there. And of course, decreased vision as a result of all of this. And what's the most common cause of unilateral limbal stem cell deficiency is ocular surface burns. Remember that there are also primary congenital causes, the most common being aniridia. Aniridia is commonly associated with limbal stem cell deficiency. In terms of management, we optimize what we've got and we add what we don't have. So surgically. So in terms of ocular surface optimization, we stop the aggressor, contact lens, topical meds. We add to the tear film, dry eye management, aggressive, control the inflammation as listed here, and then help promote differentiation of healthy epithelium. So growth factors with PRGF or PRP or autologous serum, giving the cells an environment in which to grow. So the PROS lens or the scleral lens, these are both rigid lenses that vault over the cornea to provide a fluid bath all day for the cornea. And there's also the option of amniotic membrane, overlay, either sutured to the eye if there's an open epi defect, or Procara can sit on the eye, has a little ring to maintain itself there until the amniotic membrane dissolves. And then surgical options, there's no time to go into these in depth, but just know that if it's unilateral, we can use limbal stem cells from the patient's other eye, if not at risk for some other reason. So an autograft in different forms. One example is SLET, simple limbal epithelial transplantation. That area that's removed from one quadrant is taken and cut into tiny little pieces and placed on the receiving epithelium along with a layer of amniotic membrane to help these limbal stem cells proliferate and restore the epithelium. But also a living donor tissue or cadaveric tissue might be needed in cases of bilateral limbal stem cell deficiency. Why are alkali burns worse than acid? Because alkali burns destroy the tissue as they are able to penetrate deeper. So they cause saponification of fatty acids in cell membranes and actually cause cell disruption and deeper penetration, whereas acid burns cause less damage because they denature and precipitate proteins upon contact, and that forms a barrier to the acid penetrating further. Mind you, the secondary inflammatory effects of acid are still significant, but alkali burns are typically more severe. Shifting gears, this is not a burn case. This is a 65-year-old female. She's got diabetes and hypertension. This is the exam finding here. What do we think that this is? So we can see this is in keeping with a neurotrophic epithelial defect. It's inferior paracentral. It's got those rolled edges, slightly gray, which sort of reflects some of the chronicity, and as does the pannus that's come this way. And typically it's inferior with neurotrophic cases because of Bell's phenomena. Typically the superior cornea is more protected. Now, going back to the basics, what is the innervation of the cornea? So we've got the trigeminal nerve, and then the different branches here are the ophthalmic, then the nasociliary, then the long ciliary nerves, perilimbal nerve ring, and then the corneal nerves. So the sub-Bowman basal, subepithelial plexus that then penetrates Bowman layer. So important to know the sources. In cases where we've knocked out any of these nerves, the nasociliary, the long ciliary, the ophthalmic, excuse me, not the ophthalmic, but the nasociliary, the long ciliary, we can do corneal neurotization with the supratrochlear or supraorbital nerve, for example. Cornea is one of the most highly innervated and sensitive tissues in the body, and nerves are essential for healing of the epithelium. So if the nerves are damaged, we can have neurotrophic keratopathy. In these cases, as I said, we can get pannus and even corneal thinning as a result. It's important to know our causes. They go from local causes to systemic causes. So anything that can affect the pathway between cranial nerve 5 sensation and cranial nerve 7 even, so being able to close the eye, but typically that can lead to exposure keratopathy, but typically this is whatever impacts sensation, and that's cranial nerve 5. HSV is the most common cause of neurotrophic keratopathy. In terms of medical treatment, think aggressive ocular surface management, like I said at the very beginning for dry eye. That's why I went over it then. But to add to all of that, we used to have topical Synedgermin or Oxervate. It's no longer available, but that's a drug that helped with growth of the epithelium. But we do have now topical insulin drops. And so that's something that can be ordered from a compounding pharmacy to help with regeneration of the epithelium. And then in terms of surgical management, that's stage 3 neurotrophic keratitis where they've got stromal melt and thinning, amniotic membrane, tarsorrhaphy to help with healing, glue if there's a perforation, transplant, although poor prognosis given the neurotrophic keratopathy continues, and then corneal neurotization, as I mentioned. Okay, differential diagnosis for dendritic lesions here. So really important to know what the differential here is. You'll see the term dendrite, pseudodendrite in your manuals, note to the residents, but the true dendrite of HSV is an actual ulcer, an actual crater in the epithelium with raised edges and terminal bulbs. So HSV, ocular is primarily HSV1 in adults. The HSV virus remains latent in ganglionic neurons, typically the trigeminal, and the clinical sequelae are due to recurrent disease with the actual active virus, but also the immune response. It can be one or both. In infectious epithelial keratitis, it's live virus in all cases. New presentation, recurrent presentation, there's live virus there. Various presentations include vesicles before they conglomerate into a dendrite and form then an ulcer. We showed the dendritic ulcer on the previous slide. Dendritic ulcer can progress to a geographic ulcer that no longer has those terminal end bulbs, but is just a large map-like epidefect. And then marginal ulcer, rarer, but possible in HSV. Then there's stromal keratitis. This is divided into immune stromal and necrotizing. Other names for immune stromal are listed here, so non-necrotizing or disciform. Please don't confuse disciform stromal from disciform endotheliitis. So Manis and Holland's latest edition of the Cornea book essentially recommends this term of immune stromal or non-necrotizing as opposed to disciform. The epithelium is typically intact, but there's stromal haze. There may be stromal NV and edema. As you can see here, this NV that's come into the cornea and caused this diffuse haze. And necrotizing stromal keratitis is rare, but it's the most damaging. Actually, it can be very aggressive. There's an opening in the epithelium, and there's thinning of the stroma to the point of near and even potentially perforation. It's important to have a differential for necrotizing keratitis. It's not only herpetic disease that can do this, but also bacteria, fungi, acanthamoeba, retained foreign body, and topical anesthetic abuse. Finally, endotheliitis. This is a primary endotheliitis. Stromal epithelial edema is present, but there's no stromal necrosis, and the patient does have an iritis and KPs. It's really important to monitor pressure in all patients, especially these ones. Now, the head study, this is laid out in the manual, but the key things that came out of this was oral acyclovir prophylaxis reduces the risk of recurrence of epithelial and stromal keratitis by half. Topical steroids are effective in treating active stromal keratitis. Oral acyclovir may be beneficial for active iritis. For the other three, no benefit in adding oral to topical antiviral for stromal. Oral doesn't prevent stromal keratitis or iritis developing in epithelial keratitis, and there's no confirmed risk factors for recurrence. I want to highlight some interesting numbers here. The recurrence risk for both epithelial and stromal keratitis in the head study was 18% in 18 months. In the literature, the 10-year risk from time of first attack is 70 to 80%. If someone had a prior history of stromal keratitis, that increases the risk of recurrence of another episode of stromal keratitis by 10 times. So if a patient has had multiple episodes or a really severe one that has threatened their sight, I would put the patient on lifelong antiviral prophylaxis to avoid a devastating outcome. And treatment pearls, I've made a little table here, but I do recommend that you go to this wonderful white paper that's been cited by AAO in its description of HSV keratitis, put together by Dr. Chodosh from Mass Eye and Ear. It essentially lays out the different treatment strategies for each type of HSV, each presentation. But to go briefly over it, key pearls, no steroids in epithelial, whereas steroids are needed in stromal and endothelial. With respect to dosing, the dosing for oral antivirals for geographic ulcers and necrotizing keratitis, stromal keratitis, is double that of the usual epithelial. And stromal non-necrotizing keratitis is an immune phenomenon. So really, steroids are your real treatment. It's the antivirals are serving as prophylaxis. So that's the reason for this lower dose here. Otherwise, it's therapeutic doses for endothelial as well, in addition to topical steroids. So I hope that helps sort of group things for you, but do look at that paper. You can easily Google it, and it's a really helpful reference to have in clinic. Last topic, which I can hopefully fit in 6 minutes. So corneal transplantation. So there are different layers of the cornea that can be transplanted. And the less tissue that's implanted, the less the risk of rejection. Over time, we've seen the rates of penetrating keratoplasty go down while endothelial keratoplasty goes up, because take all of those Fuchs patients, for example, or pseudophakic bullous keratopathy patients who used to have a PKP because that was their only option, can now just have an endothelial replacement. Well, that's a beautiful, less invasive, less risky option compared to full thickness. And of course, with time, as that's been implemented, that is the most common type of transplant that we're doing these days. How do we obtain and store the tissue? Typically, an Optisol GS is one storage medium that we use. A GS standing for gentamicin and streptomycin. There's antibiotics in there. Time to preservation. So from time of death to the eye being enucleated and preserved at the eye bank, that should not be longer than 24 hours. And from time of preservation to time of use should not be more than 2 weeks. Ideally, even by day 12, it would be best to use it. But we have a 2-week window to use it. Tissue quality is always checked by the eye bank. And then again, the surgeon, they give an endothelial cell count, they give the age, they give serology so you can review that everything was negative, HIV, Hep C, Hep B, etc. Endothelial cell count is given, and that helps us determine tissue quality on day of surgery, for the day of surgery. Reasons to do a PKP, so optical reasons. So keratoconus, for example, if DULC is not an option or if there was an intra-op conversion. Combined stromal endothelial pathology, a regraft, removal of a corneal opacity plus simultaneous anterior segment surgery, IOL or iris, which may be more amenable to do all at once. And sometimes we even insert artificial iris could be inserted through that opening, through the not yet fully sutured closed graft. And then scars, well, scars, even the rate of transplant for scars has gone down because we use scleral lenses more and more nowadays. And scars cause two things. They cause an opacification, but they also cause a change in the curve of the cornea. If you can eliminate the issue with the curvature causing an optical refractive issue with a scleral lens, you might be able to get away with a scleral lens and that opacity that's left over that doesn't bother the patient as much. So it's a beautiful thing to option to check whether it works for your patients before proceeding to a transplant for some mild haze that might be there. Like I said, PBK, aphakic bullous keratopathy, less PKP, more endothelial keratoplasty nowadays. Tectonic grafts, so in cases of a perforation, and you essentially just need to close the globe. This tissue doesn't have to have an optimal endothelial cell count. You just need tissue to close the globe. Once the globe is closed and the eye has settled down, you can later do an optical penetrating keratoplasty. And then therapeutic for ulcers, for example, dense corneal infiltrate not resolving with medical treatment. PKP can be therapeutic. You're essentially debulking, you're offloading a lot of the microorganism by taking that cornea off and putting on a new one. Although those patients have to be followed very carefully and continue their antimicrobial treatment until it's certain that it's not persisted or recurred. There are various intraoperative complications. Of course, suprachoroidal hemorrhage is one that is that's always a concern during open sky. When we're open sky and the host cornea is off, it's a very quick and undisturbed, quiet process in the operating room with immaculate focus on the part of obviously the surgeon, but also the scrub nurse being attentive to everything that's needed to make sure that cornea is sutured closed quickly to reduce the chance of a suprachoroidal hemorrhage while the eye is open. Postoperative risks listed here, risks that are there for all of them that are ones that we can potentially help potentiate after surgery or graft rejection and graft failure. Risk factors for rejection include the recipient being young. So just think of a young person having a more robust immune system, more robust immune reaction that could potentially recognize foreign cells and attack, especially children. Risk, if you've had prior graft failure due to rejection, you have a higher risk of it happening again. If you've had multiple prior grafts, stromal neovascularization pre-op or post-op, these bring the inflammatory mediators and blood vessels in, which can lead to recognition of the foreign tissue and then rejection. So really important to control NV. For example, in a patient that has bad MGD rosacea, really want to optimize that ocular surface and make sure they don't have chronic inflammation that's causing NV to encroach into the host and then into the graft-host junction. A large diameter corneal graft, why? Because the graft is that much closer to the limbus where the blood vessels are that can recognize it. Prior herpetic infection, prior glaucoma or anterior segment surgery, ocular surface disease or decreased corneal sensation. So any irritation to the surface that can cause inflammation, infection, etc., can trigger an immune response. Loose sutures as well, non-compliance with their steroids. And this line specifically is a Horadus line. This is an endothelial rejection line that is formed by a linear arrangement of keratic precipitates. DULC, deep anterior lamellar keratoplasty, is different from PKP in that it preserves the decimate endothelium. So if you can keep the eye largely closed, it's not open sky, automatically your surgical risk goes down. And then after surgery, lower risk of rejection and infection because the patient has their own endothelium. And endothelium is the part of recipient tissue that we react most to. That's the most common type of rejection. So avoiding implanting endothelium is wonderful. Lower rate of endothelial loss and longer graft survival. Something that might be seen after a DULC is double AC. It essentially looks like what a DMEC detachment would look like, if you can imagine that, where we inject an air bubble and reattach it to opposed to the graft. Most common indications now of endothelial keratoplasty, most common is Fuchs. Other diseases of the endothelium, including PBK. Remember, patients have to lie supine for 3 days after air is injected into the eye because air rises and air helps push the new tissue against the cornea. In DMEC, that tissue is not sutured. In DSEC, it's also not sutured unless you choose to put in a little security suture, perhaps superiorly in certain cases where you worry you're going to lose your air bubble early, like in a patient with a tube or a large PI. You target slight myopia for cataract surgeons, surgery in patients undergoing EK. So if I have a Fuchs patient and I know they're going to need a staged cataract surgery, then transplant, or if I don't know, it's sort of equivocal on their pentacam how they're doing, I'll counsel them on possible need for EK, but I'll still target them a little bit myopic because EK causes a hyperopic shift. So if you know that that EK may be in their future, you can target slightly less. So if it's a situation where it's a potential EK, we're almost always talking about DMEC. For DSEC, it's for reasons I'll mention soon, for indications I'll mention, you almost know that they're going to need it or you're doing it simultaneously. So in my practice, I don't really go more minus than 0.3. I haven't found that they need more than that. And in your books, it might say minus a quarter to minus 0.5 or 0.75, but minus 0.3 I have found to be adequate. And then minus 0.5 to 0.75 in DSEC because of the additional stroma that's in there, it causes more of a hyperopic shift. Last few slides here and we're done. Why is EK favored over PKP? Increased speed of visual recovery and final vision, predictability of surgery and recovery, less invasive surgery, less induced astigmatism. You're not dealing with all those sutures and removal of that or a weak wound either. And rejection rate is much lower because there's less tissue involved. And then why is DMEC preferable over DSEC? Better visual acuity and faster visual recovery. And then less rejection because we don't have any stroma implanted, it's just endothelium. Less refractive or hyperopic shift, fewer higher order aberrations, and less cost. DMEC, we can prep ourselves even in the OR if it wasn't prepped for us by the eye bank, stripped and marked. DSEC nowadays, we're with the automated cutting that's done in the eye bank. they have a similar rate of endothelial loss, however. And see how with a DSEC, you can actually see the rim of it here. Sorry, you can see the rim. DMEC, you can barely even discern the rim. Under higher magnification, you can, but it's just a representation of how you can imagine that there's less aberrations induced by the posterior cornea with a DMEC versus a DSEC. And then why would we do a DSEC if we have the option of DMEC? Well, poor visualization, because DSEC, we essentially pull it in. We're not depending on unscrolling a graft and making sure it's well stained so we can see the orientation. DMEC scrolls up in the eye and we have to unscroll it to open. It's essentially a cell layer thick, whereas DSEC has substance to it so we can physically pull it in with forceps or sutures. So when there's poor visualization, we're better off doing a DSEC. Multiple traps, so there's going to be big PIs, or if there's a tube, our DMEC can be caught in them. Or the air bubble can escape sooner, and we really, really rely on our air bubble to keep our DMEC attached after surgery, whereas in DSEC, not as much. We use one, but typically DSECs can do better than DMEC with early air escape through a tube. And then ACIOL, we don't want to be banging our DMEC tissue. We have to flatten the AC when we're unscrolling a DMEC. And if we're gently tapping, but if that graft is hitting an ACIOL, your endothelium is going to get traumatized, whereas pulling in a DSEC avoids that, a DSEC graft. Aphakia, well, it's easier to lose a DMEC tissue by shooting it through the pupil than pulling in a DSEC. Hypotony, and then IOL exchange. Heavier duty cases, usually a DSEC is more robust and more likely to be successfully attached to the host cornea, especially in hypotony cases. And note, like I said, DMEC has a higher rebubble rate because that tissue wants to curl on itself. It has a tendency to do that. So it wants to unscroll, whereas DMEC doesn't tend to do that. So your air fill in your DMEC cases is extremely important. Last thing to mention, we've moved from even DMEC, we're going from thick to thinner layers of tissue implanted. We've even moved to implanting no tissue for Fuchs patients. This is not PBK, but Fuchs. Fuchs patients, specifically stage 1 early with central guttae. These patients may be 2020 or 2025, but they have they're symptomatic from glare, light scatter. And so those who are significantly symptomatic may opt for, some of them might be 2040 or so actually, because of the density of the confluent guttae centrally. If the guttae are within the central 5.5 millimeters of the cornea, we can simply strip the guttae and endothelium the same way we do in DMEC. We remove endothelium and put in a new layer. In DSO, we don't take 8 millimeters or so like DMEC. We take 5.5 or 5. And we strip that and we wait. We don't put in tissue. We just give the patient Predfort and perhaps a ROCK inhibitor that helps with movement. Remember, first couple slides I said our endothelial cells can hypertrophy and move in to areas of endothelial defect. If the peripheral endothelium is healthy, as it typically is in stage 1, it's the center that's more affected, these cells can move in, and now you've removed the visually significant guttae, and you've removed contact inhibition that allows for cell migration to cover the area. Of course, the vision is going to suddenly drop. That patient's going to have swelling centrally for the first couple weeks. And then with time, this tends to improve. Usually by 3 months, they're clear if it's successful. If it's going to be successful by 3 months, they're clear. With a ROCK inhibitor, that time may be brought down to even 1 month. But by 3 months with a ROCK inhibitor, that allows for a higher chance of success. I mentally prepare my patients that this is just an attempt to save us from a graft. So they don't mentally think it was a failure if they have if they have edema that doesn't resolve. I tell them, we could go for a graft now, but why don't we try a DSO given your gluteal central, see how you respond. If you clear, we just avoided ourselves a transplant. We just avoided ourselves a lifetime of steroid use for anti-rejection medication. We avoided elevation of IOP risk that's associated with transplant. And if they're phakic, we've just avoided the steroid induction of cataract, mind you, because they've had surgery, that's still going to happen down the road anyway. But it's a beautiful and exciting option to be able to offer our patients is an early stage of Fuchs dystrophy, not doing a DMEC, but just doing DSO. If it works, you're celebrating. If they stay edematous, you've already pre-booked them for a DMEC 2 to 3 months later. So it's no surprise. They're already on board, mentally prepared. They just appreciate the chance at clearing their cornea without external tissue being placed into their eye. Advantages, no donor graft, so lower rejection risk, no lifelong steroids, increases the available donor pool, and they don't have to lay supine for the bubble to work on the graft. Decreased surgery time, less fluctuation of AC depth because we don't have to unfold a graft, less risk of cataract induction. It's a very minimally invasive surgery. We're not causing significant turbulence in the eye or AC fluctuations, and less cost. And last slide, Boston Cape Row. So keratoprostheses, this is not the only kind that exists out there, but it refers to a prosthetic cornea. So this is for totally different cases from what I was just discussing. This is for corneal diseases not amenable to PKP. So that's patients, for example, with significant limbal stem cell deficiency due to chemical burns, autoimmune disease, aniridia. These are the most common indications, or doesn't have to be a limbal stem cell deficiency patient, but patient that's had multiple failed PKPs for any reason, then this is a very nice option to be able to offer our patients. There are different types of K-pros. I won't go into it, but this is K-pro type 1, the more commonly used one. And you require good ocular surface wetting to be able to put this in. If we don't have a good tear film or good closure, this one will fail, and there's high risk of melt and extrusion. Number one thing to know about complications with the Boston K-Pro is essentially nearly 100% of patients will have glaucoma by 10 years after having this type of transplant. There's a titanium plate along with a corneal donor carrier to be able to be sutured. That titanium plate has these little holes in it, excuse me, to allow for nutrients to reach the host cornea to avoid melt. But also just the presence of this plate in the eye does affect the micromolecular environment and even the structure of the anterior segment and angle. So numerous reasons why glaucoma can ensue after this surgery. All right, thank you very much. And I'm happy to
That
take
was
questions.
oh yeah, super masterful lecture. Wonderful. Yeah. So
Thank you. My pleasure.
Sama, that was awesome. It's incredible you were able to sprinkle in so many clinical pearls with all of the high yield exam info. So thank you so much for that. Maybe we'll just get to a couple of the questions quickly. So starting here, Sama, with HSV epithelial keratitis, you probably see the question there. Can you talk to us about your personal approach to medication dosing of Valtrex?
Yes. So I'll tell you my clinical experience. I personally actually prefer to give either 500 TID. What is recommended in that white paper was 500 BID. But given that some of these cases are present with significant inflammation, and to cover scenarios where it may not be that perfect dendritic appearance, and it's more of a suspicion of HSV based on epithelial or stromal findings typically, I may opt to actually give the full treatment dose that's even for zoster. So, and that's not uncommon, I'd say, in clinical practices that I'm aware of, is even giving 1 gram TID. But really, what's recommended, if you can see that this is a classic epithelial HSV keratitis, it's got the classic dendritic ulcer, then either acyclovir 400 5 times a day or valcyclovir 500 twice a day is what I typically use as my go-to. And then remember, they're different for stromal and endothelial, and I'm happy to go over that if that's desired.
Maybe I'll just add a little question, Sam, of my own. I think you mentioned it, but can you remind me about the right patient for whom we should consider lifelong prophylaxis?
Yeah, so definitely patients who have had recurrent stromal keratitis. It's been found that having had previous episodes of stromal keratitis increases your risk of recurrence of stromal keratitis by 10 times. That's a high rate. And if we look at overall recurrence rates, 70 to 80% in 10 years of all types. It's typically epithelial and stromal we're talking about. I personally, in my clinical practice, um, I employ the principle that whether it's epithelial or stromal, and I've rarely seen endothelial, but if you've had even one visually threatening or sight altering, permanently sight altering episode, so like a central um, large dendrite, you're left with a ghost dendrite and haze, or if you've got stromal keratitis that's caused permanent reduction in your vision to any extent, then I suggest lifelong prophylaxis. And if they've had smaller episodes, perhaps they've been lucky and it has not affected the center of the visual axis, but they've had recurrent episodes. If you've had even to me, one recurrence, because I cannot predict if the next recurrence is going to be absolutely devastating or again a small flare up. It's a bit of a hard call. And when you talk to other cornea specialists about this, it's sort of that same feeling is it's almost like a gamble. And I just ask myself, what would I want for my eyes? So if I had one very severe episode, or I'd say if I had one recurrence, I'd uh, opt for lifelong prophylaxis. The thing is, with these antivirals, with any medication, you always think about the pros versus the cons, obviously, like the risks and benefit. What are the main risks of these antivirals? These are typically safe in most patients unless you have some drug interactions or kidney failure. And if you look at the alterations that you need to do for renal dosing, even in patients with compromised kidneys, I'm actually surprised at how far it goes in terms of renal function before you need to significantly drop or avoid the antivirals. Now, this has to be looked up for if any of your patients have kidney disease that's known, you need to look at their EGFR, and you can look at resources online to calculate what's the appropriate, reasonable, safe dose for any of these antivirals. But if someone's a healthy individual, no kidney disease, and has had, again, a vision impacting episode, even just one, or a recurrence, I would put them on prophylaxis because there is evidence that it decreases the risk by 50%. It's 45% in epithelial and 50% in stromal and overall, if you take them all together.
That's great. Thank you. There's a lot of interest in herpetic keratitis. I received another question here directly, so I'll ask you about it. For the patient that has a combination of epithelial and stromal involvement, do you typically delay the treatment with topical steroid until after the epi is healed?
That's a really good question. And yes, typically. So because there's technically, if there's an epithelial ulceration, adding steroids to that can worsen it, unless this looks like a necrotizing situation where you see there's actual, almost like a suppurative loss of stroma. Like these are the severe situations. Hopefully that would never be missed on exam. In those cases, it's BID. Even then, still steroids are used, even in the necrotizing form, because it just helps offset some of the damage that occurs due to the inflammation. But then you've got to ramp up your antiviral dosing. to essentially double dosing. It's essentially similar to zoster dosing. With those cases, and I know what is likely being alluded to, where it looks epithelial, like you see a dendrite, but you also see some stromal haze under and surrounding it, which may just be secondary inflammation. I still would prefer to treat without steroids until the epithelium is closed. And I have used also additive therapy. I mean, this is not in the head study, but say if epithelial defect or due to a dendrite is slow to heal, you can consider ganciclovir gel. We don't have trifluridine, but we have ganciclovir gel ointment. It also is essentially it's lubricating, but I would use that as well as an additional adjunct. If we saw that, I think what it would need to be is initially starting with no steroids, starting them on the antivirals, monitoring them, and doing adjunctive treatment as well to help with that same principle of helping with the ocular surface optimization. So what else can we add to the surface that's not a steroid, for example? Well, there's lubricating antibiotic ointments like erythromycin that can help with closing the surface more quickly so we can get on with being able to start our steroids. Also, other potential steroid sparing agents can be used for inflammation that's involved in the ocular surface, like cyclosporin, but I don't typically use that myself in the acute phase. But it's hard to say because there is no cookie cutter recipe for that question. Sometimes the epithelium closes within 3 days, you're good, you're done with taking care of that part. You can give that patient a little bit longer with their antivirals and then start steroids judiciously. For example, twice a day and monitor. See them literally back the next day. If you put steroids on an eye that's going to respond negatively to steroids because of HSV, you'll see it pretty quickly. So you could do it that way as well. Just if you want to start it soon after the epidefect is closed, you can attempt that if you feel that there's significant stromal inflammation, but be wary that there's a chance the epidefect may open as well. And this is something that has happened in some cases. You have a combination of not just that active virus that you're trying to get rid of, but also there may be a neurotrophic component as well that makes use of steroids in epithelial cases a double-edged sword.
That's the perfect segue. You mentioned neurotrophic component because we have an earlier question about oxervate. I think you had mentioned this in the context of neurotrophic epithelial defects. We have some international attendees. So is that medication just discontinued in Canada? Do you know, is it still used in the US and elsewhere?
That's a good question. I know that we don't have it available in Canada. I don't know about elsewhere. I don't believe it's used in the US either. But yeah, I believe this one is not even distributed by the manufacturer, but I'm not certain on that one outside of Canada.
Okay. And then I think the final one that we had also relates to corneal epithelial healing. I think on the slide that you presented about EBMD, among the long list of potential treatments was topical steroids. So is that something that you see used very often, and what's sort of the rationale behind that?
To use topical steroids for
I think it was on your EBMD slide. The way that the question is phrased here is, how does steroids help with recurrent corneal erosions, given that steroids are often thought to impair corneal healing?
So steroids, again, double-edged sword. Now, I have used steroids under very close supervision of the patient, and I'm talking like daily. Even in cases of, so the classic teaching is don't use steroids when there's an open epidefect. But there are exceptions to that rule. It's not a straight out rule. That's an emergency clinic first line management, always a safer rule to go with when you have an epithelial defect on presentation before you can figure out what's going on with this cornea clinically? How is it evolving with my management? I have seen in cases where, so recurrent corneal erosion, if there's not always an epidefect, a frank open epidefect. They might have micro erosions, and sometimes helping with reduction of certain inflammatory molecules on the surface. This is why doxycycline is also helpful, reduction of MMP9 on the surface. Sometimes that helps a little bit with any aggravation of the epithelium and just reduction of the inflammatory environment to allow the epithelium to heal. Same principle as managing general ocular surface disease. But you're not hitting an erosion with Predfort 4 times a day. We're talking, say there's microcysts, it's fresh. Even in that time, I'm not using steroids. I'm just using antibiotics. However, if you think about the principle of using superficial keratectomy to treat recurrent corneal erosion, right after I do that procedure, what's that patient going to go home and use? They're going to use antibiotics and steroids to try to help minimize scarring and haze that may result from the injured area. So they may help somewhat in that way. And in neurotrophic cases, even though this feels like the ultimate thing not to do, to use steroids in a neurotrophic case, really, there are cases where, because of that clumped up, those rolled up edges, it's very hard for new epithelium to try to surmount that and grow into the area. And also, if there's an inflammatory environment that's not conducive to epithelial regeneration, sometimes a little sprinkle of steroids can help. I might put a patient on Lotemax or FML after I've treated with whatever I can for neurotrophic keratopathy based on the pathway I showed. But sometimes if these are just persistent, I might give a little prescription for low frequency, low potency steroid and just see what happens. And sometimes it calms that area down and the epithelium is able to gradually start closing in. But again, this very difficult. I can't give an actual prescription regimen or cocktail because these all, in my experience, have evolved differently, especially once you get into the neurotrophic range of disease and herpetic.
Thank you so much. I think that basically covers it for the questions. So before turning it back to Edsel, I'll just thank you again, Dr. Sabeti, for the incredible talk. I learned a lot. So Edsel.
Thank you for having me.
Well, both of you did all the work. There's nothing much else to say. Just a wonderful tour de force for cornea. Um, for a person that doesn't do cornea, I learned so much, especially genetics. But a great first opening session. Thank you very much, Dr. Sabeti. Yeah.
My pleasure. I'm happy to answer any questions offline if anyone wants to shoot me an email.
There
Thank
are
you so
some things in the chat. I don't know if you can access it. There are questions from different stages there. One of it was about ivermectin. I forget which section it was. Brooklyn, are you still on? Can you ask Dr. Sabeti your question? It was earlier. It was before the recurrent corneal erosions, and then
also rosacea. So she may have been referring to blepharitis, Demodex, and potential use of ivermectin. Yes, that has been described. I don't typically use that as part of my go-to treatment regimen. I find that tea tree oil actually works very nicely. And if it's very, very hard, like very robust sleeves, like difficult for the patient to gently even wipe at night. If tea tree oil is not effective, or even upon the first office visit, we might do microblepharoexfoliation. We have a whole optometry dry eye team that has all these tools ready to go. And sometimes you need a good clean, a good fresh start, and then the tea tree oil and potentially erythromycin ointment or fucithalmic or flagyl. Yeah.
near the end of the chat, I don't know if you can access it. Somebody's talking about zoster epitheliopathy with uveitis, and they're just double checking. Can you just start the corticosteroids with the valacyclovir and not wait for 48 hours?
Generally, yes. Yes, and typically the zoster-related epitheliopathy, which we didn't go over, but typically that's an inflammatory situation rather than, with HSV, that dendritic ulcer is a sign of a live virus actively damaging tissue, whereas with zoster, that pseudodendrite, that clumping of epithelium, and the uveitis that's associated, we can treat the inflammation from the get-go and also cover with antivirals. And I
Myrna, if
don't
you're,
typically wait, just to clarify, with HSV, I don't wait 48 hours and then start steroids when there's an active dendritic ulcer. I do not start steroids when there's an active dendritic ulcer. Again, case by case basis, that 48 hours, I'm not sure where that came from, but that don't just I want to be clear not to confuse this either with the SCUT trial that has to do with bacterial keratitis, in which it has been shown that if you give the patient 48 hours of loading with antimicrobials, then even in the setting of with or without an epidefect over the ulcer, depending on the scenario, but in a bacterial keratitis, after 48 hours of loading with antimicrobials, you can consider starting steroids. With dendritic ulcers, I would say this is different because you may cause a geographic ulcer, and I'd be very wary of touching the eye with steroids unless absolutely necessary. And again, that's on a case-by-case basis, depending on how it evolves with your antiviral treatment and with time.
Myrna, I don't know if you're still on. You asked a question about Isergan. Um, I'm so sorry I don't know the context, like which section the Isergan
So
applies to.
Isergan is the brand name for ganciclovir. So ganciclovir is a topical antiviral gel that we can use for epithelial keratitis. You can use either or. You could use topical or oral antivirals for epithelial keratitis. So my go-to, just because of my comfort level, having treated HSV all these years until Gans became available last year, I start with orals. Um, and also with topicals, historically with trifluridine, you'd worry about toxicity to the epithelium as it's trying to heal. Izergan seems to be lubricating. It's a gel, but again, it's a topical drug, and the less you can use when the epithelium is trying to heal, perhaps the better. So my personal go-to is the orals, and then if I find they're inadequate, I might switch classes between the orals or do additive therapy with Izergan. And actually, I had a case this past year of a very severe geographic ulcer along with some evidence of stromal thinning that looked more neurotrophic than an actual necrotizing keratitis because of how long she had the condition and was managed elsewhere and sent from out of town. And with her, I had much hesitation to start steroids. She wasn't responding quickly enough as I would like to oral antivirals. I added Izergan on top, and within 1 week, after having had this condition for several weeks before seeing me, within 1 week, that epithelium closed, and I was able to taper her off the Izergan, kept her on the antivirals while I then treated with steroids to try to help decrease the stromal inflammation. So that actually brought us full circle to the first question, which is really nice. Every case is different, but it's a matter of using your clinical judgment based on how the eye looks and what the history is.
I think that's all the questions. Thank you again so much, Asama. A wonderful talk. And thank you for all those for attending. Um,
Thank you very much. I hope you have a good night, everyone. Thank you, Dr. Ng and Dr. Sharma. I really appreciate it. Bye.
have a good night.